I'll take on initially. Be on YouTube also. Thank you, Jatin, for that part. Jatin, you want to give the ground rules in the meantime?
Yes, if you just allow me a minute. Okay, good afternoon, good evening, everyone. This is Jatin from GACS India Secretariat. Thank you so much for participating in today's webinar. Before we start, I'll just quickly read out a quick guidelines for everyone. We have kept everyone on mute and would request all the participants to drop your comments and your questions in the chat box, which will be later picked up by us. Your videos are on switched off mode, and we would request you to keep it on a switch off mode. This is just to avoid any kind of latency in the network. In case if the connection, if you get disconnected or if the entire session get disconnected, we would request you to use the link again and rejoin. So thank you so much. Over to you, Colonel Saab.
Thank you, Jatin. Folks, another 30 seconds. And Jatin, I can't see the figure. Grid video is restricted. Okay. I think fairly good numbers now. Folks, we start. Good afternoon, everybody. This is Colonel Ashok Prabhakar here, one of the team members in Northern India chapter GACS. Pleasure to be with you all out here today. And it's also my pleasure to introduce Dr. Rahul Kalia. Dr. Rahul is Medical Director at International SOS and is based out of Mumbai. International SOS refers, admits, and monitors patients on a cashless basis in various centers of excellence across the country. For this, they have in-house medical security and operations specialists and a comprehensive network of medical and related service providers. They employ over 200 staff members and are based out of Mumbai, Delhi, and Bangalore. The staff has experience in crisis management, and it was good to learn that they've handled crises during, whether it was 9/11, the tsunami, and a whole lot of other crises which have happened in the country in the last 20-25 years. They are activated during an emergency and are available to undertake specialized projects, trainings, surveys, audits, and even those kind of activities also. This was as far as International SOS and partly Dr. Rahul is concerned. Coming closer, Dr. Rahul himself, his area of interest, apart from this training that we're going to be undergoing today, includes his interests include helping organizations in assessing health needs, preparing strategy and solutions as a health partner, supporting many Indian organizations in optimizing duty of care, thus adding to the business continuity. Now, this is very important. The business sustainability is very important, is affected by our health directly. And that is where OHS comes in, Occupational Health and Safety comes in. And that's where Dr. Rahul comes in as an advisor over there. Currently, a trusted advisor to many organizations, helping them during the current challenge of COVID-19. We've gone through the last 1 year. It's been a challenging time. And I suppose we're very fortunate that we'll have Dr. Rahul speaking to us on this activity. Dr. Rahul has also authored a white paper on occupational health landscape in India and has led many innovative solutions. What also inspires me, motivates us, is that apart from these activities, the professional activities, Dr. Rahul is also involved in Ironman. He's participated in them. He's an avid football player, a keen sportsman. And I suppose that just about as you come closer, you'll find a slim, trim, handsome young man. Thank you, sir. Thanks for joining in. We are pleased, we are honored that you're going to be with us. Thank you, sir. Dr. Rahul, over to you.
Prabhakar, thank you very much for those kind words. Yes, a young man with silver lining. I appreciate that introduction and the warm welcome. And welcome to all the participants as well. The aim of the session today is to speak about a topic that has been beaten down quite a bit over the past 1 year. However, there is still room to learn more. I mean, I'm learning something or the other every day. And I'm sure some of you will find some of what I say today interesting. I hope more than some, but setting the stage for what is to come over the next 30 to 35 minutes, we'll try and look at broad trends of COVID-19 across the world, in India and in the neighboring countries. We will look at the current problems that we are faced with. One of them is, of course, the variant strain and the various variant strains that are starting to trouble the various parts or the various countries in the world with increased transmission and the lot. We will learn a little more about them. We'll also look at what is it that you and I and our organizations can do to mitigate the risk of these variant strains. But the majority of the discussion today will circulate around the vaccines. We'll look at what are the types of vaccines. You may have heard of them. You may have read about those in the media. The media has been very forthcoming with a lot of technical lingo. We'll try and decipher that for you. And maybe towards the later half, try and stitch it all together from an organizational perspective. So with that, let's get started. And the first slide that I normally talk about is a trend line. If you were to break the world into continents, this is how the world looks like today in terms of the COVID-19 activity. The North American continent has been on a near vertical trajectory for the longest period. It is, however, starting to show a bit of a slowdown. Whether sustainable or not remains to be seen. Europe as well has been quite active. The second wave and the following waves in many countries has been quite troublesome. The UK variant has been at the heart of the problem in UK and of course in other European countries. Asia, on the other hand, has slowed down considerably, and this is predominantly because of the numbers that come from India. At one stage, we were close to 100,000 cases a day on a 5-day moving average. However, today we find ourselves around 10,000. I know yesterday was around 13,000, but then again, today it's dropped down to 10K. So around 10 to 12,000 is a 5-day moving average in India currently. Other countries in Asia had slowed down before India did. So it is for now some good news. The South American continent, however, is now starting to increase or see an increased transmission. This is seen in Mexico, in Brazil, and other South American countries. Middle East and Africa have maintained their modest trajectory. There haven't been any serious spikes or any serious drops in the case activity. They just maintain the apparent plateau. Well, Middle East is understandable. It is in the news nowadays for its unique vaccination or approach to vaccination. They're agnostic to any high-risk groups. Africa, on the other hand, is starting to see a slight uptick, but then that too is only documented from a few countries within Africa, South Africa being one of them. With that broad global trends, let's look at a few countries which may be of interest and more of a comparative trend than not. United States continues to have the most number of cases today. France, surprisingly, is the next in Europe. UK is slowing down. Of course, vaccinations and the lockdowns are helping. Rather, the lockdowns are helping and the vaccinations will help in the future. India is now maintaining its current threshold of 10 to 12,000 cases for a few weeks. Germany is slowing down. Malaysia, after a bit of an uptick, is now trying to stabilize, and Philippines is maintaining its case volume of around 1,500 cases per day. And again, these are just indicative of the West and the East, the countries which are West and East to India. What does that tell us? That it's a mixed bag. one country will not deal with COVID like the other country because of the changes or the sensitivities that are different in terms of the population, in terms of the exposure, in terms of the government's approach towards vaccination and the mitigative measures. And we're seeing those differences very starkly outlined by the way different countries are approaching COVID. Staying with the numbers, let's look at the vaccination trends today. As of today, the total number of doses administered, if you were to look at that metric, US is right up there at 44 plus million. China has done 40 plus million. But US is increasing the pace as we know it. So that divide is likely to widen. UK has done 13.5 million cases, which is appreciable. But what is noticeable is that India, within the first 26 days of the vaccination campaign, has vaccinated 7 million population. It's a good number. They're fastest to reach the 7 million mark, which is great. Worth noting that Israel and UAE are next in line, and then of course the list continues. As you can see, there are many countries. If this list was to be comprehensive, it would involve multiple countries that have at least initiated vaccinations, which is great. It's a first step towards, it's a beginning of the end of COVID, as experts call it, but it's just that it's going to take a while. Now, these data points are very important. However, these can be misleading. And I say this because what is important for us to know is the percentage of people who are getting vaccinated and not just the number of people receiving the dosages. When you look at this metric, which talks about the penetration or the coverage within a population group, UAE far exceeds the other countries, wherein it was maybe somewhere in the middle of the chart in the previous table. Israel is, after a very active drive, it has slowed down a little, but it still continues to have a very high vaccination prevalence. Other countries are listed below that. The United Kingdom has had better penetration than the United States. India is much lower on that list, with less than a percent or less than 0.5% penetration achieved. Now, what this means is the target of herd immunity, which we will speak about later, will be achieved in a few countries before it is achieved in other countries, because it eventually depends upon the total number of people that need to be vaccinated in that geography to achieve that protection. So clearly, herd immunity is far away or farther away in India than it is in UAE and Israel. That is a metric which is very important for us to track. Let's talk about the troublesome variants as they have been called by both the scientific community and the media. Europe has suffered quite a bit by the B117 variant. It is unfortunate that the variants are being named based on the country that they have been discovered. And the UK variant has been, the UK has been associated with this variant, the name at least, and then there is a South African variant and the Brazilian variant. We know, of course, the WHO is working on a common nomenclature. Let's call it the B117 strain. This one was detected in September for the first time. And from September to December, 8 to 12 weeks, it actually became the most dominant strain that was circulating in UK. So much so that it contributed to the peaking of the wave. Now, of course, it is slowing down, but not enough. Why is it doing that? What is so different about this strain than the earlier strain as we knew it? It has mutations. The virus has changed slightly, which enables it to stick to the individual cells in the chest, in the throat, and hence cause infection quicker. It infects as many as 0.7 people or 0.7 more people than the previous one did. What that means is the R naught value is higher by 0.7. For argument's sake, if the previous known strain, which has been circulating around, if somebody was infected with that, he's likely to infect 2 people. The 1 person infecting 2 people, that's the R naught value, R0 value as it's also called. The B117 strain is likely to infect 2.7 people. And that's what reflects its ability to transmit more in a community. Now, this strain itself is not likely to cause more severe infection. That is, an individual suffering or getting exposed to this virus is not likely to suffer any more than what the previous strain would have caused. However, since it is infecting more people, it is likely to put more people in hospitals because the percentages are where they are. The 80% of those infected will have a mild infection as we know it. 3 to 5% will have a severe infection. But as the volumes increase, the law of percentages that comes out means that more people will seek hospital-based care. And that's why if the hospital systems are strained like they were in UK recently, people will suffer needlessly and more people will die because of lack of timely access to care. We experienced that in India during the peaking of the first wave, where the local healthcare was almost inundated. There were no ICU beds available. And we are seeing that happen in Europe again. This particular strain is now not only limited to UK. I know there were travel restrictions, the flight restrictions imposed by many countries from and to UK. However, the strain, since it was detected in September, it is anybody's guess as to which all countries it has traveled to. 70 plus countries have documented the strain already, but it has not become the cause of concern in many of them yet. Does it or should it be considered as a threat? It should. From what we have seen it being able to do in UK, that is escalate and cause the second wave, its transmissibility itself should be seen as a threat. So what that means is, despite our case numbers slowing down or remaining at a lower level than they have been earlier, there is still a potential and an impending threat from the variants till we achieve the herd immunity, and I'll speak about that shortly. The South African variant, of course, needs to be studied more, but from whatever research has been done, we understand that this is likely to be as transmissible as a UK variant. That means it transmits more than the original strain, number one. Number two, it is likely not to respond to one of the vaccines that we know is AstraZeneca's candidate. The South African government has temporarily suspended the use of AstraZeneca vaccine because the results of the initial research has shown that this virus escapes the immunity which the AstraZeneca's candidate is likely to provide. Of course, AstraZeneca is working on tweaking their vaccine, which may be available later in the year. However, this particular candidate is devised a way of escaping the protection that that AstraZeneca or Oxford's candidate is likely to get. And this is a cause of concern. However, this variant hasn't been documented as widely spread as the UK variant is. Again, something to watch out for. There's also a third variant which doesn't feature on this screen, and that is a Brazilian variant, also called as a V3. That is yet to be studied further, but the initial results are quite concerning. It is likely to be more transmissible. If vaccines effectivity against that is yet to be determined. That variant has been identified as a cause of the recent wave in Brazil. Considering the city of Manaus, where the wave has been quite aggressive. Having said that, from our perspective as individuals and as organizations, what can we do around these variants? So the first thing is stay aware, stay informed. This is very fluid. More information as it comes our way. Our opinions will need to change based on the facts, right? So the current opinion is that yes, it is a cause of concern. However, there's not much we can do about that. But what we can do is be diligent on the preventative strategy as we know that right now. The non-pharmaceutical interventions need to continue. The wearing of the masks, the social distancing, and personal hygiene, the boring things. And I use that reference boring because that's what my son and my daughter say. They say, this is the boring thing. Why do I need to stand and wash my hands for 20 seconds? Even today, the lockdowns are over. Again, that's a perspective which I see very commonly amongst our communities. So we need to take stock of situation. We need to remind ourselves that it's not over yet. So again, the non-pharmaceutical interventions are the tools that will protect you, your near and dear ones, and organizations from the risk of transmission. The second point, which is very, very relevant for organizations, is since organizations have employees who are influenced by them, they have the added responsibility of propagating safe and professional behaviors. And these are, of course, behaviors such as when you meet somebody after 6 months, you don't take off your mask and you hug him. You know, the agreement to respect the distance and the space is still as important as it was during the peak of the wave that we experienced. So clearly, safe behaviors still need to be followed. COVID is not over yet. I'm going to change gears and take a bit of a deeper dive into the vaccines. And the reason I do that is because we realize there's a fair bit of anxiety amongst our colleagues because of the partial information they have around vaccines and the unanswered questions they have around vaccines. This may look like or sound like a microbiology class, but I'm going to try and keep it as simple as possible and not indulge too much in the technical lingo. The trials form the mainstay of the vaccine development. There are two broad categories: the preclinical trials, where the animal studies are done and the lab studies are done, followed by clinical trials. It's the clinical trials where humans are injected with this vaccine, and there are three identified phases. And the first phase, where very small group of people are identified, volunteers, of course. The aim of conducting the first phase is to ascertain the safety of the vaccine and the dosage requirement. Should it be 0.5 ml? Should it be 1 ml? Should it be, and of course, there are other units depending upon the viral load or the particle or the constituents in that 0.5 ml, the concentration of that. That is determined in the phase 1 trials. The phase 2 trials is where the immunogenicity, it's a complicated word, but in simple terms, it's the vaccine's ability to stimulate the immune system of the individuals. That is what it ascertained, along with the safety, of course. The word safety is very important because very often it is confused with the word efficacy, which is tested in the phase 3 trial. Phase 3 trials are by far the biggest trials, as in it requires multiple candidates to be recruited. Bare minimum 10,000, but we've seen 25 to 30,000 candidates being recruited by most leading vaccine manufacturers. In this trial, efficacy is ascertained. Safety would mean that the vaccine should not cause any undesired effect on the person who gets a vaccine. Efficacy means out of 100 people who are vaccinated, how many will the vaccine protect? Protect from what? Protect from either infection or disease or both. Again, this is a little complicated. Infection means exposure to the virus. Disease means a person developing symptoms and the suffering because of that infection. So if the vaccine prevents the infection, that's what we want. That means if somebody is vaccinated, he will just not get infected. Current vaccines are not able to do that with 100% confidence. Most vaccines, rather all vaccines, are able to slow down the disease or reduce the severity of the disease. That means the person might still get infected, some percentage of the people who are vaccinated, but the person will not develop a severe illness, which is good as well in the current context. However, the current vaccines do not offer 100% protection. That's a humble submission from all the vaccines that we have reviewed. Then, of course, comes the phase 4 trials, which is the longest lasting phase. We are in the middle of that right now, and it takes at times years to complete. And this is where the long-term side effects are reviewed and studied. Now, once the clinical trials are over, and there's a reason also, again, why I bring this up, is because in India, the approval of the vaccine named Covaxin, manufactured by Bharat Biotech, was done by the government. Of course, the phase 3 data was not available when this approval was given. The scientific data basis which approval was given hasn't been made public. However, the government has assured that this is safe and effective. This has caused a fair bit of concern amongst a lot of population groups. The healthcare workers themselves have shown a bit of a reluctance because they don't know how efficacious this vaccine is. It's for them, it's going a little blind. However, we are driven or guided by the regulator, that is the Indian pharmaceutical regulator, and their approval does mean that the vaccine is safe because there are experts who are doing this. Having said that, the context of what phase 3 is what I wanted to bring to you here so that you read the approval in the correct light. A quick snapshot of the vaccine development phase and the period. Again, a lot of people ask us as to whether the vaccines, because they've been developed in such a short span of time, are they still as safe as other vaccines? And the humble submission is yes. Typically or traditionally so far, vaccines have taken 8 to 10 years to develop. That's because it's a laborious process. The phases are conducted one after the other. The regulatory framework is different in different countries, and it's quite stringent. And of course, stringent regulatory approvals are required. Currently, the differences that we've seen today and over the past 1 year, wherein the vaccination duration has been shrunk from 10 years to 10 months, is that the clinical trial phases have happened in parallel. A lot of investment has come into the vaccination development, and the regulators have been sensitive to the need for approvals, and hence emergency approvals has been the route that has been taken by most regulators worldwide. All of that means that the current vaccines are likely to be as safe as the ones developed before for various other diseases. Corners may not have been cut. With that, a quick snapshot of the types of vaccines. Broadly, there are two categories: the full virus vaccine or a part of a virus vaccine. The full virus vaccine, the one that we know is Covaxin in India, which is an inactivated virus. There is a process by which the virus is isolated, it's knocked down so that it does not cause the infection. But when injected into the body is stimulated and develops protection against that virus. That's the concept of the inactivated virus vaccine. Sinovac and Sinopharm are also in that category. On the other side, the types of vaccines that take parts of virus, there are multiple technologies. I won't belabor this point. It can get confusing, but the ones that we have heard of the names, let me quickly put them in categories. Oxford and AstraZeneca's candidate, manufactured by Serum Institute of India as well, is, along with the Russian Gamaleya Institute's vaccine and the yet-to-be-seen Johnson & Johnson vaccine, are in the viral vector category. I'll show what this is shortly. The mRNA vaccines are in the nucleic acid category, where the examples are Pfizer and Moderna. Novavax, which is a protein, a part of the COVID protein or the COVID virus protein, is used to stimulate the immune system. And this is yet to be released because it's undergoing phase 3 trials. That's the broad categorization of the vaccines that we see around. The whole virus vaccine, that is the Sinopharm and of course the Covaxin, easy to develop, tried and tested technology. Many other diseases and many other vaccines for diseases have been developed on this technique. It is the vaccines do have a good response and a good immunity through antibodies, but have a relatively weaker cellular immunity. If that, it's a bit technical. However, what it means is that the immunity may not be very long lasting. That is an assumption at this stage, at least for the COVID vaccine. We haven't seen long term yet, and hence the longevity of the immunity is yet unknown. But these vaccines are very commonly found and easy to develop. The non-replicating viral vector, this is like a Trojan horse, where you take a virus like an adenovirus, which anyway causes cold, typically in the human community, humans. You take this virus, which is not going to cause a severe illness, and you insert a part of a COVID virus into this virus and you inject that into the body. And the body develops immunity for both the viruses without getting infected by COVID virus. Genius technology, like a Trojan horse, as I said earlier. Easy to develop, scalable, does not require extreme temperature maintenance. Easy, cold chain is easy to manage. Oxford, Russian, Sputnik 5, Johnson & Johnson's, all of them are in this category. The only disadvantage is that if the individual who's been injected this vaccine is already immune to the adenovirus, well, guess what? He will not respond to the COVID virus as well. And hence, the immunity will not be as strong. The AstraZeneca's candidate currently is at potentially 62 to 70% efficacy, whereas the next one, which is novel technology, this is the most recent technology that has been used to develop the vaccines. The Pfizer and the Moderna's candidate are using the mRNA technology, the messenger RNA technology. In simple terms, this particular messenger, or like an envelope with a message, is injected into the body. It enters the cell, not the nucleus, but the cell, because the nucleus has a DNA. It does nothing to the DNA of the cell. It only enters the cell exterior, or the outer part of the cell, where the message is decrypted by the cell and a few proteins are manufactured. And these proteins are COVID proteins, which the body recognizes and develops a memory for, an immunity for, and protects whenever the COVID comes, because the body already knows, attaches to it and kills it. That's how it works. Novel, genius technology. There are a few challenges in this though, and those are of the cold chain maintenance, as we've seen. Pfizer requires a minus 70 degrees temperature to be stored. Moderna requires around minus 20. Moderna is a little easier to manage than Pfizer because it can be dispensed for a longer period of time at regular refrigerator temperature. But for storage, it has to be minus 20. Pfizer has a short shelf life out of that minus 70 degrees centigrade freezer. India, unfortunately, does not have either of these vaccines available. Pfizer had applied for the emergency use authorization, but that has now been withdrawn because the government of India wants Pfizer to do a bridging trial in India, which is likely to take time. So Pfizer has committed to reapplying for that emergency use authorization. But what that means is we are not likely to see Pfizer's vaccine in India, at least for the short term. Why are we talking about the vaccines? And it all boils down currently to this concept of herd immunity that has been spoken about very actively worldwide. Quickly to summarize what this means and whether it's possible in the first place or not, the concept is that if enough number of people in a community are protected from a viral infection, for example, COVID, that they will not become the links in that chain of transmission. That means they will not become infected and hence not transfer the infection to others, and hence break the chain of transmission and protect the community overall. Once we touch the herd immunity target, COVID will stop becoming or stop being a public health concern. We want that to happen. Natural infections are giving us partial immunity. Recent research shows that somebody who's been infected by COVID is likely to be protected for 3 to 6 months from a second COVID infection. That's definite. There are antibodies that are detected in 88% of those infected by COVID for about 6 months, which is good news. Earlier, this number was around 3 months. Now we know that it's likely to be 6 months. What that means is that for these 6 months, an individual who's infected is not likely to be reinfected. So he's protected. How do we reach a target of 60 to 70%? Because if we leave it for the infection to give us natural immunity, it will take multiple years. To reduce that duration, we artificially infect people with the vaccine without the suffering. The vaccine efficacy, the lower end of this range is likely to be realistic. If a vaccine of around 80% efficacy is available, and if 40% of the population is injected or vaccinated, it's likely to give us 30 to 32% of immunity in the community. When you couple that with the immunity of the natural infection, you're likely to touch the herd immunity target. That is the hope. With the B.1.1.7 variant coming in, it is anticipated that the herd immunity target might rise from 60 to 70% to a little higher. We don't know what that number is yet. I mean, this is an assumed number. So clearly, herd immunity is not an event, it is a concept. There will not be any light or a buzzer going off once a particular community reaches herd immunity. It will only be in retrospect that you will comment that since the cases haven't climbed despite the trend otherwise in other countries or other regions, potentially herd immunity has begun. Having spoken about the vaccines and the concept of herd immunity, let's look at what are the challenges that we must keep in mind moving forwards as far as the vaccines are concerned. Demand and supply challenges are going to be big, especially in the year 2021, where the world starts to vaccinate their citizens. All vaccine manufacturers will have a ceiling capacity, and the demand is definitely going to be more than the supply initially. Distribution is going to be a challenge, especially if the temperature chains are likely to require stringent temperature management. India may not face or may not need to have a -70 cold chain just yet. The vaccines in India right now, both the Covishield and Covaxin, can be maintained at the regular refrigerator temperature, 2 to 5 degrees centigrade. Priority groups. This is the government's approach, where they've identified priority groups. The second priority group is now also being administered vaccine, that is the frontline soldiers, in addition to the healthcare workers that were already receiving the vaccines for the past 26 days. The next in line is 50 plus age group with comorbidities. That is a big chunk of 270 million people. So clearly, administration will go with the priority groups, and there will be a period. Eventually, the vaccine will become available for private consumption, where you and I can walk into a hospital or a pharmacy and get the COVID vaccine and get it injected, right? But when will that happen is the current challenge. It is not likely to happen in the short time frame because of the various challenges of the regulation by the government, them not having changed the policy for various reasons. A lot of them are the right reasons as we see it. And of course, it's going to depend on the vaccine availability. The last point here is very pertinent and one that I want to draw your attention to, and very commonly missed, is the fact that there is a lead period between an individual getting the vaccine shot and him or her developing acceptable immunity, as much as the vaccine can give you, right? It requires time. For Covishield, it is 6 weeks from the first dose. That is 2 weeks from the second dose. So what that means is that even if somebody has been injected with the vaccine, he or she will need to continue following the non-pharmaceutical interventions, not just for this 6 weeks period, but also for period beyond that. Because the current vaccines available in India, we don't know the data for Covaxin yet as to how efficacious is it. But for Covishield, it's likely to be 62%. What that means is 62 out of 100 people will not get infected, but the remaining 38 might get a mild infection. What we don't know yet with confidence is that whether these 38 will be able to transmit the infection to others while they're infected or not. The assumption is that yes, there is a possibility, and hence what that means is that vaccination itself is not equal to 100% protection. You will need to still continue the non-pharmaceutical interventions that we've learned in 2020. A few other issues, and we can address these in Q&A. And these are very, very candid questions that we receive from colleagues like yourselves. Will the vaccines prevent infection? I've already mentioned this. It will depend on the efficacy. 100% protection is not possible with the current lot of vaccines. What will the medium and long-term side effects be? Well, we don't know that yet because we haven't yet reached medium and long-term with this vaccine. Time will tell us, the phase 4 trials will tell us what the long-term effects or side effects are likely to be. At this stage, these are not anticipated to be serious or concerning as per the scientific community. But then again, a crisp answer to this question is not available. How long will the immunity last? We don't know that yet. The infection is likely to protect us, natural infection, that is likely to protect us for 6 months. We don't yet know how long the immunity will be from the vaccine. Of course, we are anticipating it will be longer than 6 months, but still, it's going to be the time that tells us, and the studies that are ongoing will tell us how long the protection is likely to be. Which age groups will respond better? Current vaccines are only licensed for 18 years plus, because 65 plus and the pediatric age group or the children age group was not included in the clinical trials. There are ongoing trials in these age categories as well to ascertain the safety and the efficacy of the vaccine. However, the current vaccines will only be given to adults. Booster, will we need a booster? Very likely, we may, but we don't have a crisp answer to this yet as well. It will be available once a vaccine's performance is evaluated over the next few months. One very important question, a very common one in that, is like we at times are reluctant to buy a car the day it's launched. We want it to be reviewed by a few experts. We want some road testing data to be available before we actually invest. Similarly, people are asking us, should I actually wait for 6 months or 3 months for a better vaccine to be available? Maybe then the later vaccines will learn from the previous mistakes and somehow be better. Well, at this stage, we don't see that possibility because all the current vaccines started development almost around the same time. Some of them were able to cross the finish line sooner than the others. But having said that, different vaccines will need to be studied and evaluated separately. We already know that Pfizer and Moderna's candidates are more effective in providing protection, 94 and 95% protection to those who receive the vaccine as compared to AstraZeneca, which is only 62%. Johnson & Johnson vaccine, which is likely to be available maybe mid or later this year, is only a single dose vaccine, and that makes it a very convenient one to choose. However, later in the year, we will be faced with even more challenges of having to select between the vaccines that may be available in a community, not just in India, but worldwide. So again, we don't have an answer yet as to whether the later vaccines will be better. Coming towards the end of my narrative, a quick snapshot of living with COVID and a few considerations. Looking back in the rear view, the year 2020 was very dynamic for us. We started as if, we started our fight against COVID as if we are on a 100-meter racetrack. We were all hands on deck, both the government, the organizations, the individuals. Anxiety and the fear was at its highest. A lot of us burnt ourselves out during that first 3 to 4 months of our response to COVID. Soon, by mid-2020, we realized that it's going to be a long, drawn process. There was an awakening once the lockdowns were in the middle, at their peak. We realized that it's going to be a long, drawn process. We changed our pace. We started worrying about the mental health of our colleagues. We started worrying about the ergonomics of individuals who are working from homes. Flexible work became the norm. A lot of adjustment had to be made both by organizations and the employees, and of course the citizens overall. But with the year 2020 rolling over, there's another awakening that is now settling in, is that it's not just a 2020 story, it's a multi-year story. We will need to readjust our pace, our responses, so that they are sustainable, so that we don't do the mistake that we did in 2020 of burning ourselves out. We have to be a little more thoughtful in making our responses sustainable. So that's a bit of an analogy for those of you who are athletically oriented, to maybe compare the pace of the various races with the pace that we will need to change as per the awareness of the COVID that we know. Vaccines are not going to be the silver bullets. Many experts have said it. We are reiterating this fact because the challenges like partial immunity, the challenges like vaccine availability, and the vaccinations, the penetration of the vaccinations in the community is going to take time. Needless to say, the year 2021 will still see COVID-19 as a public health concern. We've already spoken about the phased access to vaccination, so I won't belabor that point. The return to operations, however, from an organizational standpoint, even if a few of our employees do get access to vaccines, that does not mean that you replace other protective means that you have built in just because vaccines are available. Vaccines will come and be the additional layer of protection, not something that replaces the existing layers of protection, like screening, contact tracing, your escalation protocols, your disinfection protocols, and the lot. So clearly, this is an added module to your existing protocols. Organizations currently, from what we see around, are now ramping up and and waking up to the need to plan for the implementation phase. The difficult questions that are now being asked is, what if an employee refuses vaccination? Do I actually, or can I actually make vaccinations mandatory? Is it legally allowed to make the vaccinations mandatory? What if somebody doesn't get vaccinated? Do I, or will I have to make alternative arrangements for his job because his job description requires him to be in close contact with others? Will he be a threat to others? These are the difficult questions, and there are many more that need to be answered. An opinion needs to be formed at an organization level so that when the time comes to pull the trigger of facilitating access to vaccines for employees, these questions do not come in the way. Clearly, proactive planning is the flavor of the year, if I may use that expression. 2021, vaccination access is likely to initiate, but we will not achieve herd immunity in 2021. So COVID-19 will continue to be the public health challenge. Here's a quick Swiss cheese model that puts things in perspective. I do apologize for that arrow and that red circle, which is slightly misplaced. It was intended to be on vaccines. What are the layers of protection between us and the virus? We are on the right side, the virus is on the left of your screens. Of course, the non-pharmaceutical interventions, physical, that is social distancing, the masks, the personal hygiene, choosing your environment, being selective in where you go. I mean, if you have a choice of dining indoors versus dining outdoors, well, in the area where the cases are still prevalent, it's safer to dine outdoors because the risk of transmission is much lesser. So that is a decision you make. That is a layer of protection that you add. What about the ventilation in enclosed spaces, in your offices, in public places like malls? Is the ventilation protective against COVID? If not, well, guess what? This is going to be a high-risk space. Quarantine, isolation, all of these are layers of protection. Vaccines are that final layer of protection, which will not remove any other existing one, but only add to them. That's a concept that we need to embrace so that we accord appropriate priority to vaccines and not replace others because of the vaccines. A quick snapshot of return to operation protocols. You know, there are 8 modules that we put together for safe return to operations. I'm sure all of you representing various organizations have your own protocols in place, which is great. We are happy to help you reinforce those. But not only that, the 3 questions we ask ourselves: why do we want to get back to operations? When do we want to get back to operations? And how do we want to get back to operations? The answer to the first question is very personal to the organizations because that is dependent on the inherent nature of business. Some organizations can't survive with employees working from home. And on the other end of the spectrum is organizations which are thriving with remote operations because of the nature of work. IT versus manufacturing, there you have it. So that answer is very inherent to the organization's compulsions. But the answer to the question, when do we want to pull that trigger, is the most complicated one. And it requires multifaceted review, not only of the transmission trends, not only of the strain on the healthcare system, but also a triangulation with your preparation on site. How safe is your office premises? And the last answer, that is, how do we want to get back to operations or offices safely, is the nuts and bolts of things. While it is 80% of the effort, it is a defined effort. You know, it requires a lot of work, but it is known. There are a lot of certainties in it and few uncertainties. The most uncertain part is, of course, the middle one. When should you increase mobilization and when should you decrease mobilization? We are in the middle of course, supporting a lot of organizations, maybe your colleagues of your colleagues in other organizations with these difficult questions. With that, ladies and gentlemen, I will take a pause and open the floor for any questions and answers. Back to you, Jatin.
Great, thank you so much, Dr. Rahul. I think some of the information I'll share just my personal experience. You know, some of them are a little scary, but at the same time, they are realistic information. And we've been hearing, many things through news channels, social media, And but I think such information is really it's a requirement, and I think we all should be aware that what exactly is happening and how we can sort things out with these information. So really appreciate it. And I can also see there are many questions already there in the chat box. um, so the first one we have is from Sweta Agarwal. She's asking us, do we have reported cases of SA variant? It's 501YV2 in India.
Sure. Not that we know of. They haven't been documented yet. But since the travel has been open, well, I wouldn't be surprised if they are already here. Now, there's a difference between the variant strain being detected and the variant strain being dominant. It takes a lot of effort and a fair bit of time for a strain which spreads faster to take over and become a dominant strain. To give you an example, France recently said that only 25% of the people who have COVID positive status are because of the B117 strain. Whereas in UK, it's more than 90% now. So what that means is just because a South African strain has been detected doesn't mean that it'll take over immediately. It will need to evolve and adjust to the ecosystem, right? But at this stage, the answer to your question is no, we haven't heard of any documented case of the South African variant in India. I will, however, plug in a comment that in India, genomic analysis, which is the way you identify the identity of the virus and the variant strain, genomic analysis is not done as commonly, or there are not too many genomic analyses being done. In contrast to Denmark, where every case is being analyzed genomically to understand which is the strain that is causing that infection in every individual. I know Denmark is they've got different challenges, a smaller population, high per capita income, and a very robust healthcare system, state-sponsored, of course. In India, it's not the same environment, and hence we can't expect the same volume of genetic or genomic analysis. In India, the genomic analysis is done from a surveillance standpoint. Random samples are picked up. Of course, we did document multiple cases of B117 strain, and you would have realized that they caught the media attention maybe for a 2 or 3 week period, after which nobody spoke about how many cases exist because they stopped getting reported. It was a given that it is entrenched into the Indian community. So a very long answer to your short question there, Shweta, that we don't know of a documented case. However, since our genomic analysis is not the most, how should I say, voluminous, it is likely that we may only pick up the variants once many people start to show the signs of infection.
Great. I think it's well explained. Uh, so how soon are we see the availability of vaccine for private use?
That's a great question, and one of the most practical ones today. It is an outcome of the anxiety that organizations have, the duty of care that organizations have, that they want to protect their employees. Not just that, but also from a business continuity standpoint. Right? We all want to go back to normal lives, whatever that definition is in the current scheme of things, the redefined normal, right? However, if we look at the facts today, the government has not indicated any potential timeline before they allow the private space to start the vaccination drives. Even if private hospitals receive a nod for initiating vaccinations, the government is still likely to control the selection or the priority groups. Eventually, as I said during the presentation, eventually the vaccines will reach the shelf where you and I can walk into a pharmacy and get the vaccine and get it injected, or to a clinic, and organizations can run vaccination camps of various forms and shapes across the country. But when will that happen is still the most uncertain question to answer. There's some fierce lobbying that is happening. However, the government hasn't relented yet. And if the trend is to go by, during the COVID response, the government controlled the testing for the longest period. And there was a reason for that, because not enough tests were available in the beginning. There was a dearth of the tests available. Once the testing volume increased, the government released the control and made access to testing a little easier. We are likely to see similar approach on the vaccination front as well. Sorry, I can't give you a black and white number because I don't have one. I don't think anybody today is in a position to say when that trigger will be pulled. However, we don't anticipate that trigger to be pulled in the short term.
Yeah, I think this would probably answers the next question as well, but I would still read it out. So it is from him, and it says that do organizations have access to vaccine availability for their employees in India? Again, everyone is looking for this answer. But yet, as you have already mentioned, would you like to just add on some more?
Yes, indeed, indeed. So one must remember that the 50 plus high risk category will get invited to receive the vaccines before the non-priority groups, right? So for those of you who are on this group, who are 50 plus and who have comorbidities, you will be given an opportunity to register for the vaccine. And once your turn comes, be invited to receive the vaccine. Now, whether that will be free of cost or at a subsidized cost or at MRP, we don't know that yet. We know that the first 3 crore vaccines will be sponsored by the government, after which the policy is yet to be clarified. I know a lot of organizations have already made arrangements to offer vaccines free of cost to their employees. That's great to see. The duty of care is so encouraging. However, one must take into account that some members of your work group or your employee base might get vaccinated under the priority groups, in that, especially in that 50 plus high risk category, while the majority may not. It does influence organizations which have a population mix, young organizations with average age of 25 to 35 may not feel this impact, but organizations with mature population will definitely benefit from maybe partial risk reduction amongst their workforces before, of course, the vaccination open for the masses.
I think on the other hand, I mean nothing politically, but they're doing good in terms of putting a cap also on the pricing and things the way they have done it earlier with the testings and all. I'm sure there's something we're gonna do with the vaccines as well.
Sure, sure, and keeping with that roadmap for vaccines, when will they be available? There's another sensitivity that there are 3 more vaccines in the pipeline to be released in India. We know that the Russian candidate manufactured by the Gamaleya Institute, the Sputnik 5, is undergoing clinical trials, phase 3 trials. They are likely to apply for the emergency use authorization shortly. Maybe by mid of the year, it's likely that they might start being available, at least for the governments in India. The other 2, one is the Zydus Cadilah's candidate, which is a DNA vaccine, which is of course undergoing phase 2 and phase 3 trials. And the third one is Novavax, which is going to be manufactured by the Serum Institute of India. It is an American company, but they have an agreement with the SII to manufacture the vaccines. So our problems are likely to increase during the middle or the later part of this year, as I said earlier, because there might be many to choose from. And not all of them will be available in the same quantities to cover everybody. So we're likely to have a bigger, so to say, a challenge in objectively selecting the vaccine, if at all we are given an option to select.
And I would still say the question would remain the same, that what to choose.
Well, yeah, it should not be the source of the vaccine just because it's Russian. I know that the Chinese are refusing to take Russian vaccine and vice versa. The Americans are not very fond of the Chinese vaccine. However, one needs to understand the scientific data, and one needs to choose a vaccine basis the scientific data, both the safety and the efficacy.
Yeah.
If you go by that, well, you can't go wrong.
Great. That lead us to the next question. This is a good question here. So I think you have covered some of the things in your presentation as well. So this is about taking precautions. I mean, is it really required a precaution that we need to take either before taking the vaccine or something after that?
if you're referring to the safety of the vaccination itself, as in what do you need to do to make sure that you don't have a side effect of the vaccine? Is that the question?
Kind of, yes. Oh, is it more of a, is there something which needs to be done? Should we take care of things before taking the vaccination?
Sure, sure. No, absolutely. One needs to understand whether there is any known allergy. If you're allergic to any previous vaccine, please do consult your physician, a doctor, to get specific advice on whether you should try this vaccine or not. Because if you're likely to be allergic to a vaccine, you're not going to be allergic to the virus. You're going to be allergic to the constituents of the vaccine, or the adjuncts that are used. So that is the most important thing. Second is, if you are not in the age bracket, or if you're not in the certified condition criteria, if you don't meet the certified criteria, that is, if you're less than 18 years of age, if you're pregnant, uh, don't take the vaccine. Choose not to, because you will not be allowed in the first place. But again, set the correct expectation. From a practical standpoint, if you already have an ongoing infection, if you have a fever, if you're not feeling well, choose to defer the vaccine. Typically, vaccines are recommended to be taken only if you don't have an active infection. A follow-up question similar to this that I get very often is, what about people who have COVID? Will the vaccine cure them? Answer is no. If somebody is already down with COVID, if there are symptoms, maybe fever, maybe sore throat, and the PCR test has come out positive, well, this individual does not need to take the vaccine till he recovers or she recovers. Of course, the recovery will take, as per the Government of India, the discharge criteria, 17 days from the first day onwards, after which you can resume normal life, right? Till then, we recommend that you don't take the vaccine. You can take the vaccine after you've recovered. And it is actually recommended as well, so that the chances of a future infection are reduced. I hope that answers the question.
Yes, yes. And I believe I know the answer, but I would still like you to answer it. So the question is that the people who already had COVID uh, in past and they have been successfully recovered, do they still require the vaccination? Right.
Well, as we know that the natural infection is likely to give us some immunity. When I say some immunity, that means for around 6 months. But it's not everlasting immunity, right? And since vaccines are likely to add to that protection, there is a case for everybody benefiting from the vaccine. And that's the logic behind the healthcare authorities recommending vaccines for even those who have recovered from a recent COVID infection, so that the protection from a second infection is reinforced and increased. We are assuming that it will add to the protection. There is no clear data which tells us how many months of additional protection that will be added. We do believe that we will get this information over the next few months. But as of now, there are no known contraindications for one to receive vaccine, even if you've had the COVID infection. So the benefits clearly outweigh the risks.
Right. So that this is something related to not the vaccine one. And what measures should we take, and to get out of the COVID, the post effects of COVID? Uh, what are the measures we can take to get fully recover?
Sure, sure. Now, there is a small chunk of people who develop long COVID. Now, there's a known condition. That is, some residual symptoms last for multiple weeks after recovery. Having said that, this is the minor percentage. Majority of those who recover from COVID make a full recovery without any residual side effects. There are a few who develop either cardiovascular or respiratory side effects, which last a few months. Anything above 12 weeks or 3 months is considered long COVID. First things first, do consult your physician to get advice on how to mitigate those challenges. If there's a cardiovascular side effect or cardiovascular symptoms, you will require the management of those symptoms. There is no medicine that will cure COVID. It is only symptom management. If there are respiratory issues, you might require either physiotherapy or you might require even medications to help you breathe better and protect you from other opportunistic infections. So my humble advice is that if somebody is experiencing some residual symptoms, that you seek the guidance of an experienced physician and be guided by either the medications that they may recommend to you or a lifestyle change or some exercises and the lot. However, from a generic standpoint, I would definitely recommend one having a positive attitude. It is very difficult, I know. It is against the trend, I know. However, it is that one thing which will help you recover faster. Having a physically and mentally active recovery is going to reduce the duration of your downtime. There's a lot more that I can say, but I would limit my discussion on this subject to this. The last thing we want you to do is self-medicate and self-diagnose. Please do reach out to your favorite physician to seek that advice and help you and manage your condition.
No, I think I completely agree, and you rightly said that. I mean, one has to be very physically and mentally as well. You have to be very strong in terms of that helps you in recovering to get out of the recovery as well. I mean, there were times when I had cough for a day or 2 day, and I was kept on saying myself, it's not COVID, it's not COVID. I know it's a regular cough, and it went off like that. So great. I think we got all. Just the last one. I know the answer, so I'll just say it in a different way. I am sure that the vaccination doesn't say that you will never get affected by COVID. I mean, right? Is it right saying that? I mean, once you
Sure.
have the vaccination.
It is a way of saying that vaccines are not the silver bullet. Just because you have the vaccine does not mean that you're 100% protected from getting COVID infection ever again. The efficacy number tells you that out of 100 people that were given the vaccine, how many were protected from the infection? That is, they did not even get infected. The virus did not, they were exposed to the virus, but the virus could not do anything to them. Virus was rejected by the body. Moderna and Pfizer have 94 and 95% efficacy. That means 94 or 95 out of 100 people will be protected. We don't have those vaccines in India yet. What we have access to is the Oxford and AstraZeneca's candidate, which is around 62% effective. What that means is that 62% or 62 out of 100 who get the vaccine are not likely to have the infection. However, 38 might have a mild infection. What is known today is that all 100 are not likely to have a severe infection. That is very, very important to note. What this means, and this also is one of the reasons why the government is pushing for the vaccination drive, is because we want to reduce the strain on the healthcare system. By vaccinating people, even if they get infected, we know that they're less likely to have a severe suffering and hence not need the hospital care, and thereby leave the beds open for those who are having a more severe illness. So that's the logic behind the value that all vaccines have today, even if they have low efficacy. But yeah, the question as you put it, the answer is yes. Just because you have the vaccine doesn't mean that you're 100% protected.
Great. I think we have covered all the questions here. So once again, thank you so much, Dr. Rahul. This has been very, very informative, and we have been looking for such kind of a session and all the information which you have shared today. And we'll definitely looking forward to have more sessions like this as when we get some new things coming up related to vaccine and everything. We all are keen to know it from the real man like you. So thank you so much, and thank you so much, International SOS. I would say thanks, Rohan, for organizing this for us. And that's all we have. Thank you so much, everyone. You all have a good weekend and keep safe, wear mask, just keep on washing your hands, use sanitizer. Thank you so much.
Wish you guys all the best. Thank you for your patience listening and all the best. Bye-bye.
Thank you all. Thank you.